Okay, let's make a start then. So welcome to the annual general meeting of Hampshire Hospitals NHS Foundation Trust. My name's Steve Erskine and I'm the chairman of the trust. And this is all a bit weird, isn't it, having to do it virtually? So we very much, of course, would have preferred this to physically and met and spoken to you all personally. But unfortunately, in these times, this is the way we have to do it. And I'm sure you've all had some experience of video conferencing over the last few months anyway. I'm delighted to be here and I'm joined this evening, so I'm not going to introduce everybody by name, but just to say that we've got Alex Whitfield, Chief Executive here. We've got executive and non-executive members of our board, and I'm delighted to welcome, of course, our governors as well. I'd like to formally welcome, and I'm sorry I can't see everyone on the call, so I'm going to formally welcome people I think who are on the call. Apologies if I've missed you. So the Right Worshipful, the Mayor of Winchester, Councillor Patrick Cunningham, and the Worshipful Mayor of Basingstoke and Dean, Councillor Diane Taylor, and of course Maria Miller, who's the MP for Basingstoke. Thank you all for joining us. The agenda, you should have been able to see, we are doing two things really today. We're going to hear from some of our brilliant teams about how they responded to COVID. We're also going to have a couple of, a presentation about partnership working and a presentation about our modernising our hospitals. And on the second part of the agenda, Alex and Malcolm will present a review of the year. Can I just give you a little bit of Zoom guidance then? Because it's we have a lot of people on a video conferencing calls, lots of things can happen. So you will notice that even if you didn't do it yourself, your microphone would have been muted. And if this happens, please bear with us. It just means that we don't have a lot of background noise and we're able to hear the presentation. So if you haven't muted your microphone, if you could do that, it would be helpful. And if you don't do it, in a couple of seconds, somebody centrally will do that for you. We are going to allow questions this evening. In fact, we welcome questions, of course, but we are fairly time limited. So after each presentation, and certainly the first four presentations, we'll have time for a couple of questions. If you want to ask a question, it's really helpful if you use the chat function to do that. You can raise your hand in Zoom, but I'm not even going to start to describe how you might do that technically because it's a little bit convoluted. But if you go to the participants button on your screen, that's how you can raise your hand. You could, of course, always do this, but there's always a bit of a problem that we may not see you. So if you can put it in the chat function, we'll take a couple of those questions. If we don't get round to answering your question or we don't see your hand, then we will actually take a note of all the questions were asked and we will put those responses and the questions on the website in the next couple of weeks. So we do want to answer the questions, we just won't get to all of them this evening. And can I finally make you aware that we are recording this evening's session and every word that everybody says, because we do want to put it on the website after the event. So it needs me to explain to you that we're actually doing that, so you're made aware of that taking place. I need to just make a few comments before we start, and these are Chair's comments, and I don't really want to steal any of Alex or Malcolm's thunder from later on in the session, but there are three things I wanted to touch on that are things that we've either challenges for us this year or things that we've achieved. And the first of those is getting our good rating from the CQC. And what was most telling for me in that rating was that of 5 of the 6 themes across the CQC inspection regime, our rating improved. And the one of particular note is that we got an outstanding rating for caring. And I have to say, when you walk around this hospital, and I do that on a very regular basis, and you meet our staff, that's what it feels like in this place. It feels like our staff are caring. It feels like they're outstanding. And it's actually testament to the hard work of all those people that we have that rating improved. I wanted to touch on the fantastic opportunity we've got with modernising our hospital programmes, Hampshire Together, and you'll hear about a little bit more about that later on. But this is a fantastic opportunity to develop and build both services and infrastructure for the benefits of patients in North Hampshire. And we're going to grab that with both hands. And I know that some of you have been involved in helping us to get to the position we're at now. So that's a really big opportunity for this organisation going forward over the next few years. And then finally, of course, COVID-19 towards the end of the year impacted us in particular in the last month and a half or so of the year and had a huge impact on patients and their families. And we know that sadly, lots of people lost their lives around the country and we had our share of that. The reason I wanted to mention COVID is because it had such a huge impact on this organisation so quickly. And I wanted to raise it because our staff were absolutely fantastic. And you'll hear some examples of some of that in the presentations this evening. And it would be remiss of me as chair not to pay tribute to the commitment, the professionalism, and just the sheer will of our people to continue to do the right thing for our patients. So for any of the staff who are on this call, but for all of you, can I just formally say thank you to all of our people. Our staff were absolutely outstanding. And that's from the most senior people on this call, right through to the people working, cleaning the wards and everybody in between. You did an amazing job. And I think you saved people's lives from day one, actually, in the way that you responded to this. And it was an outstanding performance from a wide range of people in the trust. And of course, we're still impacted now. As you know, we have to restore some of our services. We're not quite there yet. It's a big job that we had to stop doing our elective work, and we need to get back to a position of being able to treat those people who all, of course, have very legitimate clinical needs as well. But it would be remiss of me not to say thank you to the staff for the job that they did. So to our amazing staff, to all of our board members and our governors, from me as chairman, a personal thank you to each and every one of you. Okay, so we're going to move on to the first of the presentations now. That's from our ED team. Now, I'm not going to read out loads of titles because it will take me longer to read the titles than it will for the people to do the presentations. But if I can hand over to ED, over to Jen, Sarah and Katrina, who are going to talk about their COVID experience through ED. Over to you.
Thanks, Steve. Can everyone hear me okay? Lovely. So hi everyone, I'm Dr. Jennifer Joyner. I'm a consultant in the emergency department here at Hampshire Hospitals. I'm going to talk to you about how A&E has had to change and adapt in response to the COVID-19 pandemic. Now, I know there might be a lot of people on this call who maybe don't know how an A&E was run before COVID. So I'm going to start by giving you a little bit before and after picture so you can see how we've changed and adapted. So before COVID, we ran what now seems to be a very simple model in our emergency department. So patients would come in either via ambulance or walking in themselves. They would have a triage assessment by a nurse, and then they would be sent to the area they needed to go to, be that for a minor injury, for a medical problem, or if they needed resuscitation. And they'd wait there to see a doctor. Now, sometimes obviously we'd get really busy, we'd get full to capacity, and then we would need to have queues either in the waiting room or the corridors until we were able to see the patients. So that's the basic version of how things worked before COVID. And then obviously COVID started and everything really did have to change. The main thing that changed initially was that all the patients who arrived before they even came into the department, they had to be assessed as being a hot patient, cold patient. And what that meant was that if they had any symptoms that might have been coronavirus, so a fever or a cough or difficulty breathing, anything at all, they would go to the hot side of A&E and everyone else would go to the cold side of A&E. And the knock-on effect of that was essentially that all our areas in the department had to be duplicated. So where before we had a single resuscitation room for our patients, now we needed a hot resuscitation area and a cold resuscitation area. So basically we had to double the size of our emergency department and run almost a second emergency department alongside the original one. And we did that to keep everyone safe, to make sure that nobody who might have COVID could infect somebody else, and we still run that model now. But obviously now when we get very busy and we get full to capacity, we can't do queuing or crowded waiting rooms like we used to. So we have to socially distance our patients to keep them safe, to keep them protected. And we've had to come up with new ways of working and innovative solutions to try and make that work. And I'm going to come back to that a bit later on. But I can't really go any further without mentioning the amazing staff in the emergency department. So we had a lot of new staff come in for the COVID response, and everybody across both the sites, from clinician consultant, from staff who were new, staff who were old, everyone came together and worked as one team to make all these changes that we needed happen, and to make sure that we could still deliver a really great service for our patients, whether they were a COVID patient or not. because it's easy to forget in the middle of a pandemic that patients still have heart attacks and patients still have strokes, maybe at the same time as having COVID. And as an A&E worker, you've always had to be ready for anything. It's what we do. But that's never been more true than during our COVID response time. And the team really did rise to that challenge. During COVID, as I said, we had lots of new staff come into the department, both doctors and nurses working in ED. And it was really incredible to see staff from different departments, different levels of seniority, different clinical backgrounds, all coming together in that united response. Everyone really did step up. And a lot of those relationships that we've developed during the peak of the COVID response, we're trying really hard to keep those going as people go back to business as usual, because we've seen how much better it is for patient care when we all work as one team, and we really want to keep that moving forward. Now, obviously that's been a positive change, but that's not to say that working with COVID hasn't been without its challenges. Of course, it's been really difficult for everyone involved. As well as doubling the size of our emergency departments, we've had a lot of new infection control procedures to follow, like donning and doffing of PPE, which can take a lot of time. And as the peak of the pandemic was developing, we had to respond very quickly to all the new medical evidence and guidelines that were published to keep up to date as things went on. But COVID-19 has really challenged us to come up with new ideas and new ways of working, and the team have really risen to that. So to give you some examples, when you're wearing full PPE, your patients can't see your face that well. So simple things like writing your name or showing a picture on that side of your gown really reassures people. Or when we couldn't have visitors during lockdown, finding phones and tablets for people to make sure they could have that communication with their relatives back home. Or when we couldn't see clinic patients face to face, setting up a virtual COVID clinic for the people we were sending home so they could be safely followed up. And those are just a few examples of the things we did in A&E. There are some really other great examples, loads of them across the trust. And I think we're going to hear some more about that a bit later on. But some of these challenges are going to be here to stay. We're going to have to learn to run our A&E in a COVID safe way for quite a long time yet, and find a way to go back to our business as usual and live with COVID at the same time. I'm sure everyone knows that after the peak of COVID, there was a drop-off in A&E attendances nationally. I think that was on the news. But now what we're seeing is patients coming in terms of numbers, similar to how it was before COVID. And combining those two things is challenging and something that we're working on currently, particularly moving into winter. It's going to bring some new challenges for us. So once flu season hits, it's going to be very difficult to tell the difference between a flu patient and a coronavirus patient. So we're going to have to be more adaptable than ever to meet that need. But we're already coming up with plans and new ways of working to keep our patients safe and manage a busy A&E during winter. So some examples of that is we're looking at setting up a same-day urgent appointment system for minor injuries so people don't have to queue to be seen. We're looking at having individual cubicles for all our patients, so we don't need to keep everybody separate in a hot and a cold department. Everyone can be kept safe in their own cubicles, and that's called an AMBER model of ED. So we're looking at that at the minute. But there's lots of work going on still. COVID and the COVID response has undoubtedly reset the way that we deliver emergency care. And I think we can definitely keep the positive changes that have happened so far, and the team are definitely going to be able to meet the challenges that we're going to have moving forward. So that's what I have to say for now. Thank you for listening, and if you have any questions, myself or the team that are with me would be happy to answer them.
Okay, thanks, Jen. That's really, really helpful. Mike, did you want to see if there are any questions? Anybody got any questions they want to ask?
Yeah, so if everyone just at the moment, because we currently have 4 screens to scroll across, any questions, please put it in the chat and we'll come back to you as soon as we can. If anyone has the facility to put their hands up or their thumbs up, I am monitoring the screen to be able to come to you to ask questions.
Okay then. So shall we move on? If, by all means, if you think of a question in a minute, put it in the chat. If we get a chance to come back to you, we will.
1 second, Steve. We have a question from David Yendall. I've just asked you to unmute, David, if you wanted to ask your question.
It's not a question. I was just going to, it was a comment. I had, unfortunately, to be taken into A&E on a Sunday evening shortly after the lockdown, because I'd fallen over, and when the ambulance men came out, they found that I had a rather high temperature. So they rushed me straight into Winchester Hospital, and I have to say I was absolutely amazed at the change that there was. But the way in which I was looked after, and the various tests I had, including a chest X-ray, which I couldn't believe I had, was had before, and a COVID test, before they identified that actually it wasn't, I didn't have COVID, but I then had to go on to a non-COVID ward for a short period of time until a physiotherapist came on Monday afternoon and said, actually, David, you're safer actually at home, so we'll send you straight home now. But I have to say, I was so impressed with everybody I saw, the professionalism, and they all seem, unless maybe me getting older, but they all seem so young. The nurses, the doctors, the physiotherapists, everyone I saw, I was just so impressed with their professionalism and the way they handled it. It was a real credit to everyone concerned.
Oh, thank you, David. That's really nice feedback. Thank you. I'm glad to see you're on the mend.
Yeah. Oh, yes. I was much. It was a urine infection which had caused it, and as soon as they gave me some antibiotics, my temperature dropped very, very quickly.
Yeah. Thank you, David. That's very helpful feedback, and we'll certainly feedback the bit about everyone looking so young, because I think there's some. There are some slightly aged people who'll be quite pleased to hear that. Michael, I think we got a question from Dawn.
We do. We've got a question in the chat from Dawn that says, are we going to have separate ward areas for COVID and flu virus patients in the winter flu outbreak?
I'm not sure I can answer that in relation to the wards, because I don't work on the wards. So I may need someone else to take that one.
I think Julie Dawes is on the call, isn't she? Or Lara, one of you two?
Yeah, I think we're both on the call. Not necessarily separate wards for flu and COVID, but we continually look to separate. So a lot of the practice you put in place for whether you've got a normal winter flu or a COVID flu are exactly the same. So we will follow all our continued practice about how we identify patients, isolate them until we know positively one way or the other and move them on. So we're still working through some of that reconfiguration, Dawn, and we will definitely still maintain areas where we have, when you're tested negative, you'll go into a negative area. If you've got any risk of infection, you'll be isolated in a side room. Or if you've got COVID positive, you go into a COVID positive area. Or if you're in that bit where you're still waiting for a result, that's in a separate area as well. So continued segregation, but not necessarily a flu and a COVID flu and a non-flu ward.
Okay, thanks, Julie. That's very helpful. So continue to put your questions in the chat room if you want to, but we're going to move on now to Stephen Kidd. And Stephen, you're going to talk about microbiology, aren't you? So over to you, sir.
Thanks very much. Thank you for the invite, for giving me a quick talk. Obviously, it's been a very challenging year, and as everyone knows, COVID is an infectious disease, and that means that kind of microbiology is what we're here for. So I've got a few minutes to just talk about an interesting project. So obviously, there's been lots of challenges throughout this pandemic, and a lot of it has been around testing. So we've responded by coming up with some innovative ways in which we can help the testing within our hospital, but also in the community. So I'm going to give a little presentation, an interactive presentation of one of the innovations that we came up with about how we can deploy testing in the community, and which we used in care homes, and also just in the testing in the community via the GP hubs and things. So I will attempt to share my screen, and hopefully the technology will not allow me down. In practice, it worked. So here we go. Right. Okay, so I hope everyone can see my screen. So we developed a rapid deployable asset for testing in care homes. We ran a 4-week pilot, which was funded by the Cabinet Office and Department of Health and Social Care. And this was in relation, working very closely with our local healthcare authorities and public health. And I will give you a little interactive tour. So this is taking the lab to the community. So this was our lab in motion. So this is our lab in a van, as we call it, or as it's nicknamed, Vandemic. So I will give you a little tour. So this is obviously me, and I had to stand still for quite a long time whilst they did all these pictures. But essentially, we've replicated a laboratory. So we were able to take laboratory grade diagnostics to the community, and we identified different care homes that were of need of testing, not just for patients but also for their staff, because obviously halfway through the outbreak the care homes were in real need and support of their testing. So here, as you can see, I hope everyone can see and there isn't too much of a lag, but as everyone is aware that COVID, or the SARS-2 virus, is nasty. And so when we have to work in the same way that the healthcare staff who are treating patients wear full PPE, and there's obviously been a lot of talk about PPE in the news, that we have to keep each other safe as we're working with patients. The same is for the laboratory staff as well. Those samples that get taken, whether it be the nose or throat swabs, we have to protect the staff who are analysing them to look for the presence of the virus. So if you can see here, I will zoom in a bit. So this is what's known as a biological safety cabinet, and this is an area which is a clean, safe space. So there is an airflow that runs through this, up through here, and then is HEPA filtered. So if you've got a very expensive Dyson, you'll have the same HEPA filtration that this. So it's very small particulates are sucked out and kept safe. And it means then that we can open the swabs and start our analysis whilst keeping the laboratory staff safe. So this was a fun process to get this into the van, and we had some real support, and we managed to design and get this up and running in 3 weeks with a lot of help from some contractors that work with the government. So as you can see, all the kind of equipment is here that we need. So we have our disinfectant wipes, we have our gloves and masks, here we've got our sterile wipes. Like with a caravan, we can hook it up so we can use off power, but it also runs off big batteries, and there's also a solar panel on the roof, so we can work, especially when we were doing it, it was in the hottest period, so we had unlimited power. And then, without going into too much detail because I'll take too much time, here's all the bits of equipment that we use. And what we can do is, if anyone wants to have a look at this, we can share the link in the chat so people can go and spend a bit of time looking at this themselves. There are some education aids in here telling you exactly what each bit of equipment does. And so we took this to care homes, we were able to test people and give them results same day. So we were able to let the staff and the public health know if they had a problem in the care home, far quicker than relying on the lighthouse labs, which were often, the beginning of that outbreak, it's probably fair to say they were quite overwhelmed, the big community testing labs. So again, here's more the other side, and these are the analyzers which look for the presence of the virus in the sample. We worked with a local company called Optigene and developed a rapid test, which is a 15-minute test, which some people might have seen on the news in the early parts of the pandemic. And this has allowed us to rapidly test people and report result back same day to have a real impact on those patients in the community. And also this technology is replicated on a larger scale within the hospital laboratories itself. And this allows us to do a lot of testing in high throughput and report results back the same day. It's all about getting those results back as quickly as possible, can make a big impact, especially in ED, and helps with the flow in the front of the hospital. And it will be obviously a challenge this winter when we start to see the flu again. So we're all preparing for that. So that's kind of where I can kind of draw to a close. I will share the link in the chat so people can have a look themselves. But one thing I'll say is that it's obviously been a huge team effort. The microbiology department is a fantastic team. We've worked very hard together to be able to support our clinical colleagues on the wards and the community to ensure that we can test people as quickly as possible, and also keep our staff healthy so they can keep caring for people during the pandemic, which is obviously very important. So I will finish sharing my screen. What I will do is I'll cut and paste the link, and I will paste it in the chat, and people can have a look themselves, and I will take a few questions if there are any.
So thank you very much for that, Stevie. Just to save you the job, Tom has helpfully put the link in the chat.
Oh, did he? Okay,
Yes.
great.
So that's
okay.
there for his brilliant presentation. So, and just before we open up to questions, Stephen, that was just one of the things that you and your team did, wasn't it? There were many other things that you did, which were first DGH to do the testing, weren't we? The swab testing as well.
In the country,
there were all
that's right,
sorts
yeah.
of things that your team were utterly brilliant. So, and we've only had time to look at that one thing there, but there were many other things, and there's some really good examples. So thank you for that. And you'll be surprised to hear quite a few questions and comments. So Mike, shall we pick a couple out?
Yeah, of course. Stephen, there's a question in relation to, is there now a quick test to tell the difference between COVID and flu, given the winter season that's coming?
Yes, there is. And we are trialling, we're working on a government pilot in the next month where we'll be looking at how we can best utilise these new rapid tests, which will differentiate flu, COVID, and some of the respiratory viruses that affect children as well. Yes.
Okay, fantastic. And there's a couple of other questions here. How positively have treatments for COVID moved on so that positives can be treated at home and to reduce demand on hospital beds?
That is probably something I can't really answer because I think, that's not really for me to answer.
I'm just going through the questions now to see if there's anything specifically for microbiology. Bear with me.
There is, Mike, while you're there is a comment here about how the service was funded. Alex or Malcolm, why don't you just pick up on that one for us?
Thanks, Steve. Both Alex and I have responded in the chat box that it was fully funded by the Cabinet Office, including the equipment that was in the van. And actually, it's a really good partnership because the Cabinet Office fitted out the van, arranged the rental of it under Stephen, Nick and Rebecca's instructions for what it was needed. So that relationship is still continuing, and we're working with the Cabinet Office now on an extension of the trial, whether that's going to have beneficial impact. But I would say that the team has been so successful that an enormous amount of people want to partner with us to develop these things, and it is an absolute. It's an amazing feature of Hampshire Hospitals that a team is doing this national groundbreaking work.
Malcolm, and sorry, Mike, can I just steal your thunder for a second? That question that Stephen asked on chat about how positively are treatments for COVID moved on so that positives can be treated at home. Yeah. Lara, is that something you can pick up on for us? I just want to try and make sure we answer the question that people ask.
Yes, absolutely. So just to point out that only a small percentage of anyone with COVID was actually admitted to our hospital. So where possible, people were actually, they stayed at home. Yes, a huge amount of research has been done into treatments for COVID. And we have actually recruited large numbers into a big national trial called the Recovery Trial, which you'll know from the media has shown some significant benefits treating with steroids. And there are other results coming out from other trials. So things have moved on, we do know more, but COVID remains incredibly dangerous to people who are clinically vulnerable and to people who aren't as well. So yes, things have moved on and the majority of people are well enough to stay at home, but we have to make sure that we remain really alert to COVID and not get too reassured that things have settled down. We haven't had any positive cases for some time, but as Jen talked about, we are very aware that we could at any time.
Okay, thanks, Lara. Mike, thanks for picking up on the questions. So if we could move on, again, if you asked a question and we haven't picked it up yet, then we'll make sure we get those responses on the website for you. So the next session is on Hampshire Together, the clinical overview, and Lara and Dominic, I think you're going to take the lead on this, aren't you?
Yes, so I'll start. So I'm delighted to be talking tonight about this incredibly positive project that's really exciting. So moving on to the first slide, this opportunity, and I know most of you on this call have been on a number of our engagement events, so thank you very much for helping with that. For anyone who doesn't know, this is part of the government's programme for new hospitals, the HIP2 scheme, with construction initially aimed for 2025 to 2030. And there's a lot of encouragement for us to go as fast as we can. Now, the money is for a new hospital, but actually we are using this as a real opportunity to work as partners across North and Mid Hampshire to develop so much more than just new buildings. So really focus on how we modernise not only our hospitals, but our health services too. And we're currently using the £5 million we have to develop our plan, and that's moving incredibly quickly. So thank you everyone for all your help in engaging with us to tell us what is important. So moving on, the challenges as to why we got ourselves onto the HIP2 list are, can we move on to the next slide, Vicky? Thank you, are around a changing population. Many of you will know Basingstoke Hospital was built in the 70s, Winchester is significantly older, and actually the condition of our buildings, particularly Basingstoke, are really becoming unfit for the services we're providing. The population has significantly increased, and we don't have the ability to expand and provide the flexible estate that we now need. And we know that the population is increasing, and that's with building, but also the number of people who are living longer, which is fantastic, but with long-term conditions who need to access hospital care. So from the clinical services point of view, we have real issues with sustaining our services and keeping the really high outcomes and standards and quality of care that is so important. And running two of many of our services means that we can't offer people the choice that we know they would need. And some of the rotas and things we are unable to maintain. Financially, this is also really difficult, and as a system, we have spent more money than we have been allocated. So actually, these four drivers for change are why we're on this list, and we need to really keep this in the back of our minds as we're moving forward with the project to make sure that we address these. So moving on, I think we've talked a lot to people in these engagement events about the vision, and the vision was really some of us thinking, what would we ideally be providing? And this is a health, wellbeing and care service to support people to access the right care in the right place at the right time. And we've gone on, moving on to the next slide, to ask our clinicians, and we've spoken to nearly 150 clinicians in the hospital, doctors, nurses, physios, OTs, in the community, GPs, community nurses from physical and mental health. And we've asked them what they think for our clinical services is most important. And what we've come up with is that the services must absolutely be shaped around the people who use them. You are local people. We want to make sure we design them together. And people will be aware that there have been previous projects with this trust where we have tried to design a new hospital, but this time is different because we're working with our local GPs, our community colleagues, to make sure we design it together and we think about all of the services, not just the hospital building. We absolutely want to support new ways of working, and I think as Steve talked about with the lab and how we've moved on with technology, and Jen mentioned the use of digital technology during COVID, it's really shown us the opportunities we have. And I just want to say how incredibly proud and grateful I am too to all the hard work of every single member of staff at HHFT and all the support from the local population, because it's been amazing. And I think hopefully it's given us all a vision for the fact that things can be done really differently. And I suspect many people who have experienced remote outpatient consultations may have wondered whether that would ever work. But actually in the height of COVID, we were doing nearly 90% of our clinic outpatient appointments virtually. We're developing the technology to make sure that's now with videos. But we also have developed remote monitoring. Steve's talked about the developments in the lab. So we really want to push this further. We want to pick up sustainability, and there are so many different aspects to this, and we want to make sure our clinical services are sustainable. As I mentioned, this is a real challenge to us. And our workforce, that we can absolutely recruit and retain the workforce that we need, the really very best. We've some amazing staff, and we want to make sure we provide them with the environment and the facilities to enable them to do their jobs to the best of their ability. We need to be financially sustainable. Of course, we need to spend the public pound as best as we can, but there's also the socio-economic and the environmental sustainability opportunities of this project. We want to make sure the environment of any building that we build absolutely promotes positive mental and physical well-being for all. And that's not just the people that we're treating or coming to appointments at the hospital, but for our staff and the people who work there as well. Our ambition is for the hospital and our health services to continue to be a massive asset to the community. We know that people are incredibly fond of their local hospital, and we want to absolutely keep that. And we're really proud of our organisation, and we want to make sure we maintain that. And also, coming back to COVID, we've really learned our buildings and infrastructure need to be flexible. They need to be sustainable into the future, so that actually things do change and that we can respond to that. So these are some of the sort of parameters we're using when we're then going on to talk, as Dominic will pick up, to talk to our clinical service, our clinical colleagues about how we're going to design our services for the future. So I'm going to hand over to my colleague, Dr. Dominic Kelly, who's a consultant cardiologist and is working on this scheme.
Thanks, Laura. Hopefully everyone can hear me okay. So yeah, I'm Dominic Kelly. I'm a consultant cardiologist. That means I do heart stuff. But really, I'm talking to you today as a member of what's called the Clinical Senate for this project, which is a bunch of doctors, nurses, and other healthcare professionals who've been brought together to help steer the clinical development of this project. And I, like Laura and many others, are incredibly excited about this project because I can assure you this trust is an incredible place. It's incredible for patient care. It's got some exceptional staff who really do put patient care at the centre of what they do. And this really is a once-in-a-generation opportunity to build on those positives, to build on those staff, and to help develop not just excellent facilities, but a whole healthcare system that improves patient care across the board, whether that be at home, or at hospital. So you see around here just a broad timeline, which, so you just go back to like a broad timeline, which is the next 5 to 10 years. So I can assure you those projects have got much more details between all these. If you wouldn't mind moving on to the next slide. So where are we now? So we've just, as you've heard so far, we've already started to engage many people. We've just spent the last 2 months undergoing many engagement events. In fact, I think we've had 59 individual engagement events with participation from over 1,000 members of the public, staff, which represent a broad area of the population. So we've had people from various charitable groups, religious groups, younger people, older people. These have all obviously been held by Zoom because of the current situation, but actually have worked very well, and it's allowed people to actually speak up in these meetings. And there's been some really amazing thoughts and ideas come out of these engagement events. And what's been really heartwarming for me is that this has most definitely not been a tick box exercise so we can say we've done something. All these ideas and thoughts that have been brought to us by members of the staff, members of the public really are starting to be intertwined with our plans for this project as it moves forward. Next slide, please, Vicky. So some of the key trends, it'd take me too long to talk about everything that's been discussed, but some of the key things that have come out of these engagement events, there's been a lot of talk about the emergency department, maternity services and mental health. But the main thing that's come out is that people want to work together. The word integration is the most common word that we're hearing. People want primary care, secondary care, GPs, hospitals to be able to work together, nursing homes, social care, etc., etc. Opinions have been split between people. Some people have concentrated most on best outcomes for patients. Some have talked about the place of where these things are provided, but actually these are not two separate issues. These are things that can happen at the same time. So we've talked about lots of things about providing things near a patient's home at the same time as improving outcomes. When we get to the staff are focused on two things largely. They've talked about clinical outcomes, what's the best for the patient, but also what's the best for people that work there, what is best for staff experience. And in my mind, I think that these two things are very much linked, because the most important thing in a hospital is not the building, it's not the equipment, it is the staff. And if we have good staff experience, we will get good staff, and that will lead to good clinical outcomes. And we already have excellent staff. And I think this just has the potential to completely snowball and allow us to build a really, really exceptional healthcare system. We've had different views between the different areas, between Winchester and Basingstoke. But again, overall, some of the trends that are coming out of these conversations have been very similar. Overwhelmingly, people are very clear that we do need to do something, and this has really given us a great opportunity to do this and do it very, very well. Next slide, please. So where are we now? We've gone through the engagement events, as you've seen, and over the next few weeks, we are continuing what's called the internal clinical reviews, which is where we're asking our clinical specialties and also our non-clinical specialties, porters, catering, etc., what they envisage for their areas, not just for now and for the next 5 years, but for the next 10, 20, 30, 40 years. And we're starting to develop some common themes. And from that will allow us to further develop our clinical and non-clinical models of how services should be developed. And then that will allow us to design the facilities to do that in an appropriate way. Next slide, please. So going back to the timeline, we've been through the public engagement. We're going through the staff reviews. The next key stage is for us to produce a long list of options. So that will be a list of various options for site and clinical developments. That will then move on to production of what's called a pre-consultation business case. And then early in 2021, we'll go out for public consultation on a number of options at that stage. And then hopefully things will continue from that, and we'll be able to continue to design the hospital with a view to opening this, hopefully towards the beginning of that timescale there of 2026 to 2030. So I'm going to stop at that point, but if there's any questions come up, I'm sure we can address those.
John, Lara, thank you very much. That was really, really helpful. Michael, I don't know if you want to pick up some of the questions that are relevant to that presentation.
Yeah, I mean, just to touch base, there's a number of questions that have been raised in the chat, and members of the presentation team have gone back and reviewed and answered the questions further down. So if you have asked a question regarding microbiology, a little bit further down the chat, Stephen has answered them for you, so we can review back on them. In relation to that presentation, there's a question from Stephen that says, would a major new hospital need nearby technology support, i.e. equipment maintenance, testing services? If so, are you looking for a site and a nearby location for support services?
So shall I pick that up? We're considering it as part of the whole project. So looking for how we would probably co-locate it. But we are working with all our partners across Hampshire and Isle of Wight in some of our pathology services for networked pathology. So that's been going on for several years, and actually that's about trying to do things more efficiently. But yes, the services we need locally, we will be co-locating with our services, either a new hospital or our existing services.
Thank you very much, Lara. There's another question here from Keith Wiggins, who's asked, I've been asked by several people how Together will support and be supported by the private sector, i.e. shared space, etc.
So I'll pick that up. We're exploring all options. So I think, as we've talked about in our engagement events, we are talking to people about whether a healthcare campus is something that local people are interested in. Certainly we can see advantages. So, you know, there are significant economic advantages to the local area of attracting business. We are really keen to expand our research and development capacity. Currently, we're really restricted with space. As Steve has talked about, during COVID, we've done a huge amount more research and the opportunities are really there. So absolutely, we're exploring the options of campus, but the money from the HIT2 scheme is specifically for hospital building. So it's looking at how much more we can think about in this project, but we wouldn't get it funded.
Okay, and then a final one off the back of Keith Wiggins has asked for Dominic, divergence between Winchester and Basingstoke on the previous slides. On which side did Andover fall? Any of the team could pick that up?
Can I answer that, Laura? Is that okay? So I would say the key things that I have seen from the peripheral areas, I guess what I mean by that is Andover, Eastleigh, etc., is their concerns about travelling to wherever the site may be. And I think Andover and Eastleigh were probably similar in that from that perspective. What we are very much focusing on is how best to provide healthcare for the whole area. And I think what is becoming very frequently mentioned is being able to provide lots of things actually nearer to people's home, because we have a central mass within a new site. So what I mean by that is currently we are running 2 large sites, and if we centralize some of our services, that actually frees other people up to go to nearer to people's homes. So if I use cardiology as an example, we have centralized over the last 5 years or so most of our cardiac services to Basingstoke. So if you are unwell with your heart, you go to Basingstoke. But if you need to see me in clinic, or if you need a scan of your heart or lots of other things, because there are more consultant bodies within that Basingstoke population now, we can then go out to peripheral clinics. So you can be seen at the War Memorial Hospital, you can be seen in Winchester, you can be seen at Alton Hospital, etc. And that, I think, has been the concern of the areas of Andover and Eastleigh. And I think our plans will be to actually improve accessibility for those areas rather than disadvantage by being able to provide those, I guess, hub and spoke models of care. And I think that is one of the themes that's evolving at the moment. But as I said, we are still developing this, and that certainly isn't what has been decided as a final model. It's just one of the thoughts that's come out.
Thank you very much, Dom. Just to reflect on the expansion of that, there's a question here from Alice that says, have you considered clients from West Berkshire and how it would affect them if you move away from Basingstoke? And then also expanding on that, John Bird has also said, please don't forget the rapidly expanding Alton area, RE travel to a new site. If any of the team could pick that up.
Yeah, so we are absolutely thinking about all of the people who look towards our hospitals and health services. And when we're thinking about site, we're looking at the implications of travel, accessibility, absolutely. So we know that accessibility and how easy travel, car parking is really important to people. That was a very strong theme through the initial engagement. And that's really helpful because that's going to really feed into our decision making. So we're absolutely thinking about everyone. And we know that people, as Dom says, want services as close to home as they can when that provides the care they need. So we do understand that.
Okay, thanks, Lara. Thanks, Mike, and thanks for picking those questions up. Keep your questions coming. Any others we'll pick up, as I said, on the website. Can I just move us on then? So the last of this section of the agenda is partners working together for patient care. We're going to touch on telemedicine here, I know, and I'm going to hand over to Ruth, Naomi and Charlotte. Thank you.
Thank you very much, Stephen, and good evening, everybody. It really is lovely to be here with you this evening, and particularly to talk about such an exciting thing as working together and some of the experiences that we've shared. So by way of introduction, my name is Ruth Colburn-Jackson. I'm the Managing Director for the Clinical Commissioning Groups across North and Mid Hampshire. And we're responsible for working with partners and our communities to determine and secure the health and wellbeing services that you as our local population need. And as such, we've worked in partnership with a range of partners, including our hospital colleagues, for a number of years. And I think it's fair to say that our shared COVID experience really has accelerated that way of working. And we're going to share with you some of the experiences that we've had with some particular benefits. So over the pandemic, we have worked really hard together to make sure that you, your families, your friends and your neighbours in our local communities have been able to access the care and support that's been needed over this extraordinary time. And there are some really clear examples of how we've done some of that work. So we've been working really hard to reach out to those who've been shielding, to make sure that support has been needed, has been available to people. We've been working on increasing how our services have used digital platforms so that patients can attend the appointments, both virtually in GP practices as well as in hospital care, and achieving remote prescriptions and ensure that access to reduction in physical contact to meet the social distancing requirements. We've done some work around increasing acute and community capacity, which has been needed over this period, and it has also enabled us to work with some new partners, which again has been really, really exciting. So what we're going to talk to you a little bit more about is a very specific example around care homes. And what's really lovely is we've already heard from Stephen about some work we've done with care homes in our local place. And there's also been some really exciting work done in primary care around hot and cold site access, which Jen has already referenced in her experience around ED. So a lot of the work is absolutely around joint partnership working, and the experience we've had around supporting our care homes really has been exciting and really innovative. So what I'd like to do is I'd like to hand over to Charlotte and Naomi, who are going to introduce themselves and tell you a little bit more about the project that's been initiated there.
Thanks, Ruth. So it's great to be here this evening to talk about this really exciting project that we've implemented at speed over the last few months. So my name's Naomi, I'm a pharmacist and also Associate Director for Clinical Integration, and I'm really delighted to be doing a double act with both Ruth and Charlotte being GP and CCG Clinical Lead for Integrated Care Teams. I think we've probably also got on the call Sam, although I can't see that at the moment because I've got the slides in front of me. But Sam is a physio and also the service manager for the telemedicine service. So you can see already that it's a multidisciplinary approach, and we really have got a wide range of clinicians supporting this innovative service. So this service really is about bringing the clinician out of the hospital and virtually into the care homes, just to give you a bit of a top-line summary. And as background, Hampshire Hospitals and CCG developed a bid, probably autumn, winter last year, end of last year, to set up this telemedicine support service for Hampshire and Isle of Wight. And this was really all about integrating health and social care for some of the most vulnerable in our society. And as I said, providing that clinician virtually into the care home environment for the benefit of our patients. And this was based very loosely on the success of the Airedale model in North Yorkshire, which has been up and running for about 10 years and operates over a geography of around 500 care homes. And their main outcomes that we wanted to emulate moving forward were a lower demand on GP services and a reduction in some of our hospital service demand face-to-face. And I guess what was really important for us, and the reason why we wanted to implement this locally, was really to ensure that we could individualise care, both for our individual patients, but also for our local population, and to enrich and support our local workforce to look at providing care for the whole patient journey, rather than perhaps some of the individual areas that we're perhaps more familiar with looking at. Next slide, please, Vicky. Vicky, there, next slide, please. Brilliant. Okay, thank you. So where are we now? Well, that, as I said, that bid was developed at the back end of last year and was due to roll out this service probably around this time, August, September time, at this time of year. But we have implemented early due to COVID, and I'll talk you through that because it's happened in a phased manner. So we've developed this centralised telemedicine service for homes across the Hampshire and Isle of Wight footprint in a phased way that will ultimately get to the full Hampshire and Isle of Wight geography of around 600 care homes, those with residential as well as nursing care. And the service is really all about providing instant access to patients in their own homes, in their own residential home, when they have a sudden and unexpected health need. So this is not replacing any GP services or any current services in existence, but really trying to provide that hospital clinician and other clinicians out into the care home environment so that those patients receive faster care. And where that's not possible, what we've achieved is enabling those patients who need to be in the hospital setting to get into that environment quickly and to get to the right place first time. So that service is now up and running and is available 7 days a week. And it's located within the A&E footprint at the Royal Hampshire County Hospital. And the real benefit of that is that, of course, we're looking at those urgent sudden deterioration situations. And those patients often would have previously come into A&E. So what we have is the medical support, if necessary, from those specialised clinicians, if needed, through that virtual platform. Next slide, please, Vicky. So this is very quickly just to show you the geography that we're talking about. Now, those red circles that you can see, we've had planned pre-COVID to set this service up in 3 discrete areas to around 25 to 30 care homes in the Basingstoke, Winchester and Romsey areas, just to test and pilot that service. And that was due to start August, September time right now. What we found is that obviously the care home residents were particularly in need of this service being brought forward. And so we've put an immense amount of work into doing so. And in April this year, we launched this service for approximately 85 care homes across the North and Mid Hampshire footprint, which is roughly the Hampshire hospitals geography, if you like. And then we've rapidly escalated that to the point now where we're at 166 care homes, which includes some of our Southampton and Southwest geography. And within the next few weeks, we'll expand again to 240 care homes, and we'll rapidly go on from there. So what was a service that was due to be implemented over several years has been rapidly accelerated to provide individualised care for some of the most vulnerable in our community. And at this point, I'm going to hand over to Charlotte, and she's going to just talk you through some of the ways we've done that and the benefits.
Thank you, Naomi. It truly is a double act, which I hope reflects the bit that I'm going to talk about, because I've absolutely loved being part of this project, and it's fitted my 2 roles as a GP, because I've actually done some clinical sessions as part of the team actually in the service, speaking to patients in care homes, as well as being part of the team setting up the programme. So I really think that it's due to the collaborative working that everybody has embraced that this has been so successful. And who do I mean who's been collaborating? Well, this slide says it all. Obviously the care homes, the acute hospital where the service is based, but it's much more than that, because I think we've reached out as well as the community reaching in. The primary care out of hours has been involved, and they've been part of providing some of the care that some of these patients may need. GPs, we've been collaborating, and I truly feel that with the way it's worked, it's enhanced and helped GPs, but they've also helped the telemedicine service. So definitely a 2-way process. We've had engagement and a huge help, and they're helping to evaluate the project from the Wessex Academic Health Science Network. Sometimes the ambulance services have been involved, and they've been absolutely embracing this project. Obviously, the CCGs, as part of my role, have been involved, and we speak to patients, carers, relatives, and actually that's the essence of this, isn't it? About improving their care. So I think it's been particularly important as the group of patients that the telemedicine service is trying to improve the care of have actually been those that have been potentially one of the most vulnerable groups during COVID, and actually I think generally are vulnerable per se and have been slightly forgotten. I think centrally the Department of Health have recognised this, but I feel really proud that our system has recognised this and seen it as a priority and put in an actually first-rate service. So what do I mean by that? So here are some facts and figures. If we can move on to the next slide. I'm not just saying this is all about cosy teamwork, although I think that is actually vital and really important to provide better patient care, but the figures speak for themselves. So if you remember, we set this up in April. Oh my gosh, in 2 weeks, what normally would have taken probably a year. And since then, we've taken 269 calls from care homes, prevented 98 ED attendances, and we've been constantly looking at this data. So I do feel it is it's good data. Now, those aren't just preventing attendances or admissions just for the sake of it. These are those admissions and attendances that I think we've all felt haven't been appropriate and actually have provided less good care. So the patients are still getting care, but in a better place rather than in an ED department or in an ambulance. So although we prevented 62 admissions, actually 28 patients have been very appropriately admitted to hospital, but we hope given the right care quicker and directed to the right specialty more effectively. So what improvements has this created? I think it's improved communications, it's upskilled staff. We've all learned from each other, both in and out of hospital, brilliantly. It's improved some of our processes like respect forms, which is around the advanced care planning. And I truly think they've been a more collaborative effort with the care homes and patients and relatives. And as a result, reduced admissions and reduced the delayed transfers of care from the hospital, because if we're reducing the patients going in, we're giving the patients who are in hospital a better opportunity to be looked after where they should be and then discharged more effectively too. There's evidence we've reduced 111, 999 and out of hours calls, and increased the amount of specialist as well as generalist care in the care homes. I hope this means we've reduced duplication and touch points and improved, therefore, the patient experience. So all in all, I think that speaks for itself, and I think we are really proud as a team of doing that. Next slide, please. I think this is the soft stuff, but is so important. This is what it means to people. These are just some of the comments, which I won't read, but I'll give you a little bit of time to read through. And this is very much feedback from care home staff and patients. But I think there's equally good feedback from our staff, both in secondary care and primary care, and within the team itself. And I think I'd like to sum it up saying I'm really proud of the team providing the service. I'm here and Naomi's here speaking. I know Sam is behind a screen somewhere, but actually we're just part of the team. The bigger teams are an amazing group of people, both in and out of hospital. I feel very much part of it, but the rest of the team deserve the most of the praise. And that team is not just clinicians, it's also an amazing digital team, both at the Trust and also at the CCGs, and our partners across the system who I've mentioned already. Everyone's embraced the new service. I think it shows what we can do in a very traumatic time, such as the COVID pandemic. There is still more to do. I think it's really exciting what might be possible with this, because this service may well be possible not just in care homes, but also in patients' own homes. But it's an excellent example of fantastic teamwork. So thank you for listening.
Thank you for that. So Ruth, Naomi and Charlotte, thank you very much for that. Mike, have we got a couple of questions?
Sorry, there was a few questions from Dawn and Doug that have been answered a little bit further on by Lara. Thank you again, Lara and Alex, for picking up some of the questions. There is a question, does this service support community in-home caring companies too? From Jackie Porter.
Thanks, Michael. So I think by this question, we mean the domiciliary care companies that come into patients' own homes rather than the care home setting. And that's very much something that we are considering for the future. It's not a service that we currently provide. As you can imagine, we have scaled this up very quickly. And actually what we found as a result, that there are lots of benefits that we could realise in different settings. And one of those would absolutely be patients' own homes with that domiciliary care. But we also know that we can probably utilise this in other settings, such as mental health and learning disability care homes. We can look at chronic illness and how we provide care from the hospital currently, and whether we could do that differently. So what we're trying to do at the moment is really provide the service that we do well and to the scope that we've originally planned, whilst looking at what are the future plans. How can we work together as part of the Hampshire Together programme and with our partners, and really try and look at this whole patient pathway using the digital functionality to the best of its ability to really complement the clinicians working with it within all of those settings. So the short answer is not at the moment, but it's part of the vision moving forward. And I suppose the other thing just to say is that we set up the Holiday Inn as a step-down facility from the hospital, which was very much provided on that basis with domiciliary care within the Holiday Inn. And so we did provide the telemedicine service out to the Holiday Inn as well, due to the COVID crisis, really.
Thanks, Naomi. Anything else, Mike?
Yeah, there's additional one there from Dawn. It would be so beneficial if patients could see their own GP on one unit without having to go between 2 or 3 different sites, then be directed through the process on the one site, saves time and the continuous seamless service. We could pick that up.
Okay, yeah, absolutely. So I suppose at the moment what we're doing is differentiating between that usual GP care, which is utterly important to be provided by your usual GP, and this is not attempting to to do away with that in any shape or form. And this service is all about the sudden deterioration and trying to support that in a home environment where possible. I think your question is maybe around trying to navigate some of that for patients, because I think we all recognise that sometimes it's a little bit complicated. We try and implement all these things and suddenly there's an array of choices available for you. So I think that's possibly around your question. And from the care home setting, we do a lot of training. We've done a lot of engagement with the care home staff so that they understand which service they can use. And we're also very linked in with the 111 and 999 service. So if calls do come in through a route that we would rather deal with in a different way and would be more appropriate for a patient, then we can, we're all in that together, and we can redirect them so there's no sort of delay for the patient. And Charlotte, did you want to add anything?
Yeah, yes. I'd also add to that. I think if a call comes in for an acute deteriorating patient that we deal with in the telemedicine service, that doesn't mean to say we're not communicating back with the GP, because it's really important they're aware of that. So they will get notification both electronically, but also often we will give them a ring and do it jointly and share that. I don't know if some of your question alludes to the how primary care is set up with the different sites and working across, which it may be as well. But I hope that we can, the way that telemedicine is linking with primary care, hopefully between primary care centres and units, that will also be a development, and technology is helping us do that. But it's actually about communication, isn't it, as well, and for the patient, how to access that. So not getting handed off, and if you go in via one unit, that unit will then take you to the right place rather than you have to be transferred. So I completely understand your point, I think.
Hey, Charlotte, thank you for that. Again, any other questions that were in the chat, we will pick those up at a later point. I do want to move us on because we do need to do the review of the year. I hope what you found is that those presentations are a real mixture of the things that we're involved in at the moment, and it ranges from people in the hospital, our staff dealing with COVID, right through to how that partnership working. And the thing that I do know is that partnership working is the way forward. Integrated care is how we will deliver better care to patients. It's absolutely vital. And although COVID was a really difficult time and it was really challenging for a lot of people, there were things that came out of that that showed how we can work together for the benefit of patients. And it's really important that we don't lose sight of that. So thank you to all of our presenters. Brilliant, as always, and it's been very helpful. We'll come back to the questions, but now I'm going to hand over, I think it's to Alex to start the review of the year, and then over to Malcolm. So Alex, over to you.
Thank you, Steve. And the only downside with having amazing colleagues is that you have to follow them at events like this. So massive thank you to all of the people who've talked so far. Okay, so it's my privilege and pleasure to just take you through the year 2019-20, which feels like it was an awfully long time ago. Technically that finished in end of March 2020, but I am going to tell you a little bit about COVID, which is kind of what's been happening since then, and a little bit about looking forward to 2020-21. So that's the plan. So as always, our mission is summarised by these 4 strategic objectives. The first is about outstanding care for our patients, and that's absolutely our driving force and vision. The second's around our empowered people. The third is living within our money, and the fourth is innovating for the future. And as always, underpinned by our care values about compassion, accountability, respect, and encouragement. And I'm just going to tell you a little bit about what we've done in each of our 4 quadrants, although Malcolm will pick up the living within our money quadrant when he gives you the financial update on the year. So just to orientate you, this is our geography. As you can see, and there's been comments in the chat, we absolutely own and love the people of West Berkshire around the Newbury area, out towards Alton, over to Andover, down to Eastleigh, and everything in between. Our 3 major hospital sites at Andover, Basingstoke and Winchester are only part of our offering, and a number of our colleagues work in Alton Hospital, in GP surgeries, and as you've seen already, in the odd van that's driving around the county as well. So 2019-20 in numbers, here are some key numbers around the number of people that we saw. The outpatient one always amazes me because that's about 11,500 people a week who have come to meet a doctor, nurse, therapist, psychologist, dietitian, whoever it is that they're meeting in an outpatient setting at Hampshire hospitals. It's a lot of people. I would also pick out the lab tests carried out, over 8 million of them. I don't know how many Stephen himself personally did, but 8 million lab tests is quite phenomenal. The number that really defined the year 2019-20 is the one I've put in the sort of star. So one of the things you will hear through my bit of this and through Malcolm's is the unprecedented increase in admissions that we had, urgent admissions, unplanned admissions to the hospital, which was up 9.3% as a year average. And actually it was a lot higher than that until February time when COVID hit. And then actually we saw a reduction in the number of people in February and March, but the year average was 9.3%. And in terms of our theme for the year, that drove a need for additional staffing, and that drove some of the financial challenges that we had in the year. Next slide, please. So outstanding care for patients. So of course, the first thing here has to be CQC, and Steve has already alluded to this. We were inspected in January, we were rated good overall, outstanding for caring, and on that little chart at the bottom that you see on the bottom right, every single one of those categories went up, except for the use of resources, where we remained at requires improvement. And our challenge for the year has been our financial sustainability. But I think in terms of the quality of care around safe, effective, caring, responsive and well-led, our colleagues across the trust did a phenomenal job, and I'm glad CQC recognised that. But we aren't stopping there. We want to get to outstanding. It's really important that we learn. Here's some quotes from the CQC. Staff treated patients with compassion and kindness, took account of their individual needs. Staff worked well together, and I think we've heard a lot about how we're working collaboratively. I think the thing that I would say I felt most proud of was that one of the bits of feedback that the CQC gave us was that wherever they went, people had taken the previous CQC inspection really seriously and had embraced the learnings and the lessons and wanted to make things better. And this overwhelming desire throughout the organisation to always try and strive to be better, recognising all of the stresses and strains and financial constraints and all the other things that we live within, there was a real desire to improve things for the lot of our patients. And it was really inspiring to hear that from the inspectors. What our patients say, so what you can see in this slide here is the National Friends and Family Survey. I know it's a bit small here, so if I just say the summary of this, so the pink columns are the people who would recommend our service, and there are 4 different blocks. There's ED as the emergency departments, then top right is inpatient care, then bottom left is outpatient care, and then the 4th one is maternity care. So you can see in all of those services, the pink blocks that would recommend are higher than the blue blocks who would not. The yellow blocks show you the percentage of people who responded to the survey. So it's really the pink versus blue you're looking at. And actually throughout all of these areas, the number of people who would recommend our services vastly outweighs the number who wouldn't, which is very good. And that our recommendation rates for all of these were either higher or the same as the national average. And our wouldn't recommend are lower than the national average. So that is really speaks volumes of our colleagues who work across all of these services. Next slide, please. These are some of the quotes from our patients. And again, I'm not going to read them all out. The thing that I think when I look at some of these is that the environment that we care for patients in is the thing that is important. And you'll see it in the staff survey quotes in a minute as well. So one of the things here about the emergency department was the new surroundings made it much nicer for patients and staff. And we have upgraded our emergency departments, unfortunately before COVID, and we now need to increase them again, as you've heard from our colleagues and from Jenny and others in the ED. But the environment is important. But despite the challenges we have with some of our environments, our staff are amazing and really positive, from dementia care to maternity services. In terms of our performance, so there are some key metrics we're measured on nationally, so we will share those at the annual general meeting. The cancer waiting times, we did a lot better this year, and you can see they're all green bar 1, so we met all the national standards. And I know people who are very au fait with this will recognise these, but for anyone that isn't, about just below the midpoint, there's the cancer 2-week wait. What that means is that if your GP thinks you might have cancer, then you should be seen in the hospital within 2 weeks, within 14 days. And we met that for 94.5% of all of the patients that the GPs referred through to us, which was very good. So that's across any type of cancer. We're also being a pilot for the 28-day faster diagnosis test, this second from bottom one. And this was about that actually within 28 days, you should know if your diagnosis is cancer or not. Now, in order to know that, you have to have been seen by a specialist, you have to have had various diagnostic tests, those tests have to have been interpreted and reported on, and then we have to have told you, no, you don't have cancer, or yes, I'm afraid you do, and we're now going to start talking about treatment options. To do all of that in 28 days is very tricky. The national target that they've been trialling is that 70% of people should get that information within 28 days. And we hit 81.4%, and that's in the first year of doing this. So again, a huge tribute to the colleagues who work in cancer pathways. The one we didn't quite meet was the 62-day wait for first treatment. And some of our specialties, in particular, urology has been a bit of a challenge with that for prostate cancer. But we've done a lot of work, and actually as we came towards the end of the year, we were meeting that more reliably. This is an annual number that you see here. Other targets, so diagnostic weights, the national target is that 99% of people should have a diagnostic test within 6 months. And we, 6 weeks, sorry, not 6 months, 6 weeks. We hit 97.2, so just slightly missed that. But our infection control performance has been exemplary. So 0 cases of MRSA and 45 cases of C. diff versus a target of no more than 60. Now, I know for some of you, 45 might sound 45 too many, and I would agree, but this is a complex infection, which isn't always a result of poor practice within the hospital. It can be a bug that people have inside them that comes through as a result of the medication they're on, or a variety of other reasons. So that's why the target has been set at 60. Keeping that to 45 is very good. And for our emergency access target, so you've heard from our colleagues in the emergency department and some of the real challenges that they have had, particularly during the COVID time. This target has been disappointing for us, but if I show you the graph at the bottom, which runs from April 2018 to March 2020, the blue line is the number of people coming to the emergency department. And what you can see is that in the second half of that graph, the 2020 attendances were significantly higher. And I think we all slightly got tired of having record-breaking attendance days, as kind of one day after another, we had more and more people arrive in the emergency department, and it made it very difficult. The red line you can see is the number of people who got seen, treated, and sent home or admitted to hospital within 4 hours. So that is a target that we have been working on. It requires not just the whole hospital, but the whole system to ensure that patients flow quickly through the departments. It's absolutely a priority for us. And then here's just a few of the examples of some of the things that we've been doing in outstanding care for patients. So improving our emergency departments and our wards, domestic violence and abuse advocates, lots of WOW nominations, which is our sort of staff recognition thing, where patients, families, carers, visitors and colleagues can nominate Hampshire Hospital staff for a WOW award, and we had over 3,700 of those in the last year. We've had lots of thank you notes and other things to reflect on our care. So in terms of empowered people, Vicky's accelerating me through quite appropriately. Staff survey. So we survey all our staff every year, and we ask them a whole raft of questions, and we track how we compare in the responses to how we fared the previous year. And in our staff survey in the last year, 2,800 staff responded, and 28% of the questions asked had a significant improvement on the previous year, with the vast majority of the rest of them staying the same in terms of the statistical significance of any kind of change in response. So we were really delighted with that 28% of the questions had improved on the previous year. We know we've still got lots of work to do, and making our staff feel valued, appreciated, looked after is a really important part of our plans. It's something we've been focusing on and will continue to focus on. Some of the comments from the staff survey are in the next slide. And again, lots of lovely things about positive changes, but the environment that we ask people to work in is definitely an issue. So things like the difficulties in physically getting to work and getting parked are challenges that staff don't need. So we can't not mention parking, although it is something that COVID has improved. The hospital interior and exterior and the environment are issues that get raised here. But people really enjoy working at HHFT, respect and dignity valued highly. So this is our values shining through. Big focus for our empowered people objectives in the last year has been recruitment and retention. So we know that one of the reasons people feel stressed at work is because they simply don't have enough colleagues around them to look after the number of patients that need our care. So we've had a real focus on retaining staff, making staff able to develop their careers while staying at Hampshire hospitals, to work flexibly while staying at Hampshire hospitals, to feel valued while staying at Hampshire hospitals. And we've also had a focus on recruitment. And last year was our best year ever for internationally educated nurses. We recruited 131 of them. It was amazing from the recruitment side, the training side, the induction side, the welcome that our internationally educated colleagues have received in the teams that they have joined. And the thing I would particularly like to say to colleagues who've come through this pathway is they are a total inspiration. So many of them come to the UK without necessarily knowing other people here. They start a new job. We then put them through a very intense training so that they can pass their exams to get their PIN numbers. And they do it with such dedication and positive attitudes. It's just wonderful. So we're really delighted, and we are continuing to recruit internationally educated nurses this year, COVID allowing. So it was a strong year overall, and we managed to increase the number of staff in the trust. Training and development, so very important to invest in this. We launched in May 2019 an online learning platform called Green Brain, a different way of learning. It has transformed our ability to provide training to our colleagues. It's just amazing. It's so easy to use. Staff love it. It's had a massive impact on our mandatory training compliance rates, but actually it's quite enjoyable to do your statutory mandatory training these days. We've got things like our emergency department was awarded the Emergency Department Learning Environment of the Year by the Royal College of Emergency Medicine. That is an award where junior doctors nominate their departments that they're in based on the quality of the learning environment and the training support. And that's really tricky to win. And we were absolutely delighted that, that our colleagues won that award. Our venture between University of Winchester and ourselves goes from strength to strength, and I think I saw Simon Jobson on the list of attendees. So thank you, Simon, for all the support from the University of Winchester, who are now into their second year of nurse training and third year of physiotherapy degrees. And we had a really great meeting with them only this week about all the other ways we're working together collaboratively to improve our staffing and training. And our apprenticeship programs going from strength to strength. And we've had our second year of Project Choice interns. This is individuals with learning disabilities, learning difficulties, or autism who come and work in our teams, do an internship, and then for the most part go on to have a substantive job with us and start their careers at Hampshire Hospitals. A really exciting program. And diversity, so absolutely celebrating diversity. In fact, I think, Maria, you're in one of these photographs, so it's good to see you there. We've done lots around diversity this year, and there's lots more happening. Rainbow badges, multi-faith rooms, our inclusivity network had a big conference, and we have all sorts of things going on and lots of plans for the next year about how we continue to really work across all of our colleagues to make sure absolutely everybody feels able to reach their full potential and is supported and valued in their work here with us. I'm now going to hand over to Malcolm to take you through the money side of it. Malcolm.
Thanks, Alex. It really does seem a long time ago, doesn't it? The end of the year. Vicky, could you? Right, okay. So quickly going through last year, the financial results were very disappointing. I think Alex has alluded to lots and lots of the very good things that are happening in the trust, but the financial deficit, the operational financial deficit for the year was about £20 million higher than the planned deficit that had been set by our regulator. And when we add in all the additional funds that we get for hitting various targets, and also a special supplement for our urgent and emergency care, we published a deficit of £9.7 million against a planned surplus of £14.5 million. And it really did feel like a year of three halves. At the start of the year, we were in conversation with our regulator to alert them to the fact that we felt that in setting the budget for this year, we had not got consistent plans to tackle our underlying deficit of about £8 to £10 million. But we had some really good ambitious plans, particularly around reducing the average length of stay of patients. And while we achieved that, the sort of second half of the year became this unending picture of increases in ED attendances and increases in non-elective care admissions to the hospital. Alex has been a bit of a data purist by going March to March in those. But if you take out the impact of COVID and do a January to January comparison, our ED attendances were up 8.7%, and our non-elective patient admissions were up by 11.5%. And Jen has already described what that felt like as a clinician working in ED, and then the sort of slight respite in numbers, but huge increase in complexity when we got to COVID. And that really was the third part of the year. Even though COVID reared its ugly head in the second half of February, it did have a significant impact on our finances in the last couple of months of the year. Vicky, if we can go on to the next slide. Sorry, this is a bit busy. It probably works better on a 20-foot screen in the ARC than on your iPad or a mobile device. But we've tried here to just get a like-for-like comparison by taking out the impact of a technical adjustment to pensions, whereby the cost of NHS pension scheme went up, but the Treasury funded that cost. But in order to get whole of government accounts in order, it had to notionally give the Trust £12 million for the pension costs, and then notionally take £12 million away from us. But the other part in that middle column, where we're trying to get a like-for-like comparison, is the cost of COVID. I'll come back to that in a later slide. But even in those about 6 weeks where we were really where it's from the first patient appearing in the locality, we spent an additional £4.3 million in those 6 weeks on COVID care, and the preparations that we were making to protect our staff and other patients from cross-infection. Next slide, please, Vicky. This is a longer term slide, and I think this illustrates one of the really big issues about NHS financing. I've taken this back to the point where we merged with, where Basingstoke and Winchester merged. And the startling element of that is the growth of the salary costs over that year. So while our income has grown by just about 35% in those 7 years, our staff costs have grown by 52%. And what that has effectively done in financial terms is it's prevented the expenditure on non-salary costs, and some of the issues around our estate are a sort of function of that. And we have not been a poorly performing trust in financial terms. For the first 4 years of this comparison, we were making small deficits on average. In the last 4 years, since the availability of provider sustainability funding, we've made on average a small surplus. But one can see that we are not spending enough on our physical estate. We're not spending enough on our on equipment, and undoubtedly there are very many areas where we're not spending enough on staff. But quite clearly, we're straining at the levels of financial sustainability now. Vicky, if we can go on to the next slide. This is the impact of COVID. So just in those 6 weeks, from the middle of February to the end of March, we incurred £2.4 million of additional staff costs, £1.9 million of non-staff costs, and we lost about £0.3 million in income. That is largely around car parking, catering, those sorts of elements. Some specific services that we had to stop, and obviously then we didn't get payment for it. All of these have been included in our 1920 financial statements, and all the revenue claims have been paid capital costs have been confirmed as to be reimbursed. As I'm talking about COVID, I can't, it would be completely remiss of me not to record a huge thanks to the professionalism, the compassion and the resilience of all of our staff over this period. It was an immense privilege to work with our staff across the board within the Trust, our clinical colleagues working in awful circumstances with PPE in very high temperatures, our stores people providing supplies 7 days a week, our catering staff making sure that free food was available to staff all the way through the day. It was, and hundreds of other teams putting themselves at significant personal risk at the start of this this crisis time. It really was a privilege to be part of this Trust during that time, as it is in normal times, but it really did emphasize that. Alex has absolutely correctly highlighted some of the feedback that we've had in terms of our staffing reports and CQC reports, but substantial increase in staff. And I think there's a line very early on in the CQC report that staff reported that there had been a significant change in the number of staff in the Trust, and that has made their care to patients and their support for each other much easier. But there have been substantial financial consequences in that. And the earlier slide was showing an 8% increase in our staff costs, and this was based on the number of staff who were working in the Trust. This includes substantive staff, agency staff and bank staff. You can see the increase there, and overall in the last year we did increase by about 7% in whole-time equivalents. Again, the really happy bit of this slide is that a lot of the great majority of the increases have been in clinical staff, in our nursing staff and our medical staff and other clinical staff. So we are putting the money where we need to put it. Undoubtedly, there are still very severe shortages in some areas, and we are, but at least there is a substantial increase in those staffing. But obviously that then does get part of the reckoning that we have in financial terms. And I've just put at the bottom of there the staffing within unscheduled care, where we've had an 18% increase over the year to cope with the additional demand from our patients. Next slide, Vicky. Right, quite a few people have asked me about the announcement on government announcements about the write-off of NHS debt. There is a difference between debt and deficit, in that we are incurring a year-on-year deficit at the moment. But the very good news is that potentially repayable short-term funding that we've drawn down in the last 4 or 5 years has actually now been rolled up and is being redesignated as public dividend capital, which still means we pay a capital charge on it, but it means it is no longer repayable to the NHS as a debt. And the calculation of our interim loans was 20.5 million. So next year's balance sheet will see this money not shown as a loan, but as public dividend capital. So I think that's a positive change in our position. Next slide. Next slide. Right, capital investments. Again, we have done some things in the last year or so to improve our estate. Winchester ED has been really substantially changed. Again, we need more space in that area, but now it is transformed from the estate that it was 2 years ago. We completed the Countess of Brecknock Hospice just after the year end, but again, that's a fantastic facility for our patients, and a huge tribute to the Countess of Brecknock Hospice Trust for funding that. Thank you to everyone involved in that. It really was a magnificent £4 million fundraising. Just after the year end, we completed work to increase the capacity of our high dependency unit and the fracture clinic in Basingstoke. We've continued to make investment in digital healthcare to improve patient safety and to allow our clinical staff to do what they want to do and what we need them to do, which is to make more time for direct patient care. Again, there's a quiet revolution happening in this area, and when going on to wards to watch direct e-observation as opposed to paper and pen recording of patients. Again, that was a direct criticism of us in the last CQC report, but we've sorted it. But there are major risks remain in our core infrastructure. The boring stuff that you can't see, drains and electrics, and the very interesting stuff that you can see, like our cardiac catheter lab, which is desperately in need of renewal. So these remain very important deficiencies for the trust to address. I usually point out the magnificent support from our associated charities and donations to the trust. This year has been off the scale, particularly in the COVID period. I've already thanked the huge generosity and commitment of the Countess of Brecknock Hospice Trust, but the Hampshire Medical Fund has done amazing work over the year. We've had major pieces of equipment, and Hampshire Medical Fund was instrumental in raising huge amounts of funds to support us during the COVID period. And the Winchester Hospice fundraising charity is also now getting towards, I think we're up to at least 85% of the funding that's needed for the Winchester Hospice. But please keep giving. The project is on its way. The builders are in there, and hopefully this time next year we'll be reporting that is completed. I think Alex has alluded to the health infrastructure plan, and Dom and Lara spoke at length about it. This is a fantastic opportunity for the trust and to be able to give our population healthcare facilities that they deserve, and our staff the facilities to work in that they deserve. Again, a thank you to everybody who's been making the arguments for this in whatever forum that you've made them. That's been really important to us, and now we just have the little matter of delivering this as quickly as possible for our population and for our staff. 2021 feels completely surreal. It feels as if we're in the Big Brother house sometimes with finances in 2021. There's been real active and constructive leadership from NHS England and NHS Improvement to fund COVID costs and recognise the collapse of activity. All providers have been funded to break even between April and July, and that's now continuing into September. And we've been given the cash to make sure that we're able to buy equipment and employ more staff during this time without worrying that we're going to run out of cash and need access to interim loans. There are uncertainties after September, as we've got the sort of triple issue of we need to restore activity to levels that look a bit like they were before COVID, and we need to protect against nosocomial infections within the trust, and we need to have sufficient capacity for any COVID surges. This really is quite a complicated position to be in, and will challenge us in many different ways to the challenges we've had in the last 6 months. And also we're accessing COVID-related capital, which has been made available by the government at different phases. The Trust has claimed just under £5 million of capital for the first phase of COVID. We've submitted bids for another £1.7 million for the next phase, and we have some very major bids in conjunction with our STP organisational colleagues for the restoration phase. However, we're very mindful that while the NHS has been treated generously during this period, and the government has almost uniformly met its commitments to the NHS, money is going to be tight in the future, and we still are a financially stretched hospitals in a financially stretched health system. Thank you to all my colleagues. It's been brilliant working with you all year, and it's just a shame that the financial picture isn't a little bit brighter.
Thank you, Malcolm. So that was our third quadrant about living within our money, and where we are with that. So our final quadrant, innovating for the future. I've only got one slide because I think you've heard so much of the innovation that has been going on in the earlier presentations. Digital care program, as Malcolm said, it is amazing what's been going on there about electronic patient records, about virtual appointments through telephone or video, and a whole load of other things improving our patient record system. Countess of Brecknock Hospice that Malcolm mentioned, this is a picture of it. If anybody hasn't got over to Andover to see it, I would highly recommend it. If you want to know what a new build healthcare environment looks like, it is stunning, and we are incredibly grateful for the people, all the people who helped raise the money to build it. It's absolutely beautiful. Winchester Hospice ongoing fundraising, and then HIP2, the health infrastructure plan. That was a real success, I think, last year, just getting on that list, and we are incredibly grateful to all the people who helped to make sure that we were on that list and give us this opportunity for our population, plus all of the other innovation that you've heard of this evening. So COVID-19, I said I'd just give you a couple of slides on this so you know what's happening. This just shows you the number of patients we had in our beds for COVID. So the yellow line is the total, the blue line is Basingstoke, the green is Winchester. Andover didn't have any. We kept Andover clear. We had a few patients who had at one point in their history had a positive COVID test and who then had tested negative and went to Andover for rehab. But basically Basingstoke and Winchester were where they were at. You can see that at one point we were at over 150 patients in our hospital beds with COVID. That was back over the Easter weekend in April, and I think we were all quite worried at the rate that line was rapidly increasing, and we were struggling to know how on earth we were going to cope if that trajectory continued going up. But luckily, due to all sorts of reasons, and probably most particularly the population locking down and behaving and washing hands and socially distancing, it didn't keep going up, and in fact flattened out to the extent that we have had no positive patients in our hospital for over a month now. So every member of Hampshire Hospital has gone above and beyond, and I think you've heard all about that. This is the lab in a van that you've heard about this evening, and the fact that we were the first lab outside Public Health England to actually be able to test for COVID. And I think that did make a big difference. We were testing not only patients coming to Hampshire hospitals and staff at Hampshire hospitals, but we were testing people from the local ambulance service, the GP practices, the community mental health providers, and social care and care homes really early on, and that definitely helped to flatten that curve. Our last positive test in our lab here was on the 2nd of July, so that's encouraging, and long may that continue, but it continues to have a dramatic impact on how we work. And the final bullet point here about restoration is really speaking to Mindy's point earlier. So I don't know if people saw in the chat, but there are a lot of people who didn't get treatment over March, April, May, June, because we stood down an awful lot of our planned work. And our key focus now is trying to get those patients back into care. It is hugely challenging. So it is challenging because of all of the very necessary requirements that restrict the number of patients we can see at any one time. And if I give you a kind of stark example of that, endoscopy, which is the sort of test to find out if what's going on in your tummy and in your digestive system generally, we used to be able to see, to put 9 patients through that test, a diagnostic test in a morning, or 9 patients in an afternoon. Because we need to be extra specially careful around our COVID restrictions, as we are instructed to do nationally, we can only now get 5 patients through a morning list. And as we didn't have empty rooms sat doing nothing, or staff sat doing nothing, there isn't a very easy way to increase that 5 back up to 9 again. So not only are we struggling with the fact that there were a group of patients who didn't receive treatment, we're also then restricted on how many patients we can treat of the new people who are coming forward. So a huge amount of organisational focus is going on to try and work out how we can see as many patients as possible for diagnostic tests, for treatment, for surgery. And that really is our main focus as an organisation at the moment. And I'm acutely aware that there are a lot of people whose care wasn't emergency, and we kept seeing all the emergencies, we kept treating the cancers where it was really, really time critical, but there are an awful lot of patients who are living in pain or reduced functionality or in anxiety about what's wrong with them, who it might not be urgent, but it's absolutely important, and we need to get these patients treated or tested as soon as possible. That is our key focus right now. So what's next? So Malcolm's given you a bit of a sense of that. I have just got a sort of single slide here, or 2 slides here, which is, one is our strategic objectives remain the same. They are about outstanding care for every patient. That is about COVID-19 patients and all the other patients that need our care. Empowered staff, we are really prioritising staff well-being. Continued focus on retention and recruitment, making Hampshire Hospitals an amazing place to work where people can spend their whole careers, develop all sorts of skills, feel loved, valued and appreciated. Living within our money, we need to work within the resources allocated to us, and then continuing to innovate for the future, seeking out international best practice to ensure we provide the best care we can, and working with our colleagues across the system to join up care as part of our strategic programmes. So those 4 objectives, which we set a couple of years ago now, have stood us well, and we will continue to focus on these 4 things in the year ahead. And the only other thing is just a reminder that this is probably our biggest, outside of COVID and restoration, our biggest focus in the coming months, which is our Hampshire Together programme. It's been really inspiring to work with colleagues from across the health and care sector, and outside of that, because we've been working with local authorities, boroughs and districts, not just in the social care environment, but in all sorts of other ways that we support care for our population. And with business and with universities and with all sorts of other people to shape the future of healthcare in Hampshire. That is all of my slides, just some beautiful pictures of some of our amazing staff, and I just want to add my own personal thanks to all of the colleagues that I have the pleasure and privilege to work with each and every day. They are an inspiration to me, and I'm incredibly lucky to do the job I do and get to work with these phenomenal people. So thank you, everyone.
Thanks, Alex, and thanks to you, Malcolm, as well. Mike, did we want to pick up a couple of questions?
The majority of the questions in the chat have already been answered. There are a few other questions from previous presentations that we have picked up, and we will make sure they get back and answered via the FAQs on the website.
Okay, thanks for that, Mike. There is one there from Peter from Neighbour Care Basingstoke about the group in North Hampshire finding demand for transport for both to Basingstoke from elderly people is still quite low. Might this increase soon? I don't know, Alex or Lara, if you wanted to pick up on that.
Yes, it's really interesting. So one of the questions really early on was what are we most sort of proud of through COVID? And one of the biggest changes that's been alluded to throughout has been this shift to virtual, what we call virtual outpatients. So either telephones or videos. So the long-term plan said we should get to 30% of those happening on the telephones. During COVID, as Lara said, we got up to about 90%. We know that the right answer is probably somewhere in the middle of that, but we are consistently seeing, you know, half of our outpatient appointments or more happening over the phone or by video, and actually that working really well for patients and for clinicians. And I think that's having a major impact on the number of people who need to physically come to the hospital. Now we're working to get that balance right, but definitely that will have an impact on the number of people needing a volunteer driver to bring them into hospital if they can stay at home and have their appointment virtually, and it is still of the same quality, because we're not trying to compromise quality here. And then I think the other thing that might be affecting it is we are not back to our full activity levels, as I described with endoscopy. We are still not able to see as many people for diagnostic tests and for surgery as we were seeing. We're working as hard as we possibly can to get those numbers back up again, so that will affect it. We're also still doing some limitations on visiting in order to minimise the number of people coming into hospital to help with the reducing the spread of COVID. And prevent a second wave. So I think there's quite a number of reasons why fewer people are coming into hospital, and that will have an impact on the volunteer driver demand as well.
Thanks, Alex. As Mike said, we'll pick up the questions later on. I just, Neil, you made a comment about hospital radio and your offer to help get message across as we continue to develop going forward. So thank you for that, and we'll pick up on that. Thank you for all of your comments. We will respond to all of them as part of some FAQs, and we'll put those on the website. Just to remind you that the annual report and the summary of the annual report are available on our website. It was laid before Parliament on the 24th of June and presented to the Council of Governors on the 21st of July as well. Just in closing then, just to say thank you to a few people. So thank you to all of you for joining today. I hope you found that enlightening and interesting and helpful, and I hope we got a wide enough range of subjects that you found interesting. A huge thank you to all of the people who were speakers and presenters this evening, because it's not always that easy to do it virtually, but I think we just about got away with it, didn't we? And also a big thank you to the comms team, because I know you've been working in the background to make this really work for both the presenters and for the people joining the AGM, and I think you can take a pat on the back for that. I'd like to personally thank my board colleagues and the Council of Governors for not just your contributions throughout what has been quite a difficult year in a number of different ways, and a very successful year in other ways, as both Alex and Malcolm and some of the presenters have picked up, but also for the personal support you've given me, and that's been enormously helpful. But most of all, and it sounds like a broken record because we've all said it, just a huge thank you to our outstanding staff, because without your commitment, without your hard work, without you being utterly brilliant in the most desperate of times, and that graph that Alex showed, where it showed the spike in cases that we had, there was a point in the middle of that time, in the middle of April, when we didn't know what the future looked like, and our staff were the people who came to our aid, weren't they? Our people stepped into that game when nobody knew what the outcome would look like. Nobody really understood the risks, and they were utterly brilliant. And it was because of that, and because of the community doing what they needed to do, that we managed to get on top of that situation. So my final thanks, my heartfelt thanks, is to every single person in this organisation, every single person who went above and beyond what they needed to do. And that was people in the clinical settings, people who redeployed, people who were shielding at home, people who had to work from home. And all of those people, not only were they doing the job here, they were worried about their own families and their own children at the same time. And they were utterly fantastic. So that's the note I think I'd like to leave the AGM on. And it's the utter commitment and professionalism of our people. So thank you very much for your time. I hope you've enjoyed the AGM, and we'll see you soon. Thank you.
Thank you, Chairman. Bye.